So I'm Frank Spear. Welcome back. In the previous lesson, we had talked about sort of the critical questions that we need to address concerning occlusion. And in this lesson, I want to walk through sort of how our beliefs about occlusal philosophies have changed over time. Classically, if I look back at the 1970s and 1980s, when I was a young dentist or even in dental school, I wanted to know what the right answer was. I wanted to know that there was one way I should do occlusion and it had to be the right answer. Today, looking back on over 40 years now in dentistry, there's a part of me, I used this as a title in a lecture last year. I said, the title of the lecture was, I wish I knew what I thought I once did. And what I mean by that is really simple, is I thought that there was one way. And, it was nice when I thought there was one way. And then it turned out that my one way didn't work on everybody. And suddenly it wasn't so nice anymore. And so let's just take a little brief couple-minute trip through the philosophies that existed and then sort of what they had in common. Because there used to be a lot of arguments about occlusal philosophies, about really minute differences, but in sort of the major philosophies, there's a lot more similarities than there are differences. So in my training, I was trained nathologically in the mid-1970s, and nathology had a very strong belief about how occlusion should be developed. The condyles should be seated, and the argument was, at one point in the 70s, that meant pushing the mandible back with your hand into the, quote, the rearmost position. Then it became the rearmost uppermost position, and then it became the most anterior superior position. But at any rate, their goal was to use the joints to tell the mandible where to close. And then they developed a very specific occlusal scheme with an anterior guidance that was actually related to the steepness of the eminence of the jaw joints, and posterior disclusion, so when the patient moved, the posterior teeth didn't hit. Bioaesthetics came around right around the early 1980s, and it was an offshoot of nathology. And basically, bioaesthetics took, again, an approach where they seated condyles. They typically used an appliance to do it rather than manipulation. And then they also developed an anterior guidance, and they had some parameters about the depth of overbite and the amount of overjet, but very similar in reality to nathology as far as anterior guidance, posterior disclusion. They were a bit more rigid in some ways in terms of the size of anterior teeth and the depth of overbite. And then you had Pankey and then Pankey-Dawson, who, again, wanted to use a seated condylar position. Typically, it was achieved with some form of manipulation, but it was an anterior superior position. And again, they wanted to use anterior guidance, posterior disclusion. What Pete Dawson brought to the table was the fact that patients need a customized anterior guidance. That is, not everybody can have a deep overbite. Some people have to shallow out the overbite to get the teeth out of the way. And then back in Seattle in 1968, Barney Jenkelson invented the myomotor, and that was the birth of the neuromuscular version of occlusion. And really, it was significantly different than the other three in that, in fact, instead of using the joints to determine where the mandible should close, it uses a TENS device and electrically pulses the muscles and watches the trajectory of the mandible and builds the occlusion in that position. And the neuromuscular approach typically was not as concerned with overbite, anterior guidance, because the belief was if you got quiet muscles by putting the mandible in the right place, people wouldn't grind their teeth. And I can tell you, because of having been trained nathologically and then exposed to bioaesthetics and then teaching for years at the Pankey Institute with Pete Dawson, at one time or another, all four of these believed that if you did the occlusion correctly, your patients would stop grinding their teeth. Now, nathology, bioaesthetics, Pankey-Dawson, they're actually quite similar. Neuromuscular, definitely different. But here's the problem. They all work. In most patients, any one of these works more than they fail. And in reality, this isn't what most dentists do. If I were to bring in 500 dentists who practice on a daily basis and say, what do you do about your patient's occlusion? Very few of them would tell me that they utilize any of these. So what's the most popular occlusal philosophy historically? It's what we call the conformative philosophy. You use what's there. You're going to do a couple teeth here, you just use what's there. Ask the patient to bite. Grind left, grind right, grind forward, make sure your crown's not in the way. And so the confusion we have historically about occlusion is, if only one approach worked, it would be so easy. It would be like if there was only one dentin adhesive that actually worked and everything else failed. You'd go, oh, buy that one. If only one approach to occlusion actually worked and everything else failed, easy. The challenge is multiple approaches to occlusion work. Historically, if we really looked at those philosophies, they were seen as a way of controlling muscle activity. In other words, the thought process was if you did the occlusion correctly, your management of the occlusion would actually cause muscles to stop doing bad things, to quiet down. So that what we believed was basically bad bites, occlusal interferences, led to tooth grinding and muscle pain. And therefore, if we correct the occlusion, people will stop grinding. If we correct the occlusion, people's muscles will get better. Now, the truth is, in some patients, that is true. In some patients, you can get significant differences in muscle and joint pain by managing a patient's occlusion. But we're in a different place today because we have so much more science around all of this than what we had before. So where are we today? What's different? The major transition for me surrounding occlusion has been, instead of thinking that by doing a certain occlusion, I'm going to take control of the patient's muscles. Based on the research we have today, what I tend to believe now is more often I'm going to do a certain style of occlusion so that what I do survives the patient's muscles. Because I don't believe that we can manage the patient's muscles and control them at the level we used to think we could. So bottom line was, the way I was raised in dentistry was simple. If you looked at this little animation of this skull, if the patient came in and when they bit together everything fit, but when the condyle was seated they had interferences in the back, my belief from when I started with nathology in the mid-70s was that interference, that shift between those two positions, that was what caused people to brux, that was what made people grind their teeth, that's what made people's muscles hurt, and therefore it was all about eliminating interferences. Now, I totally still believe in eliminating interferences when we're treating patients who need treatment, but I don't necessarily believe it because I think it's going to control the muscles the way we used to think. So if we look back at nathology, bioaesthetics, Pankey-Dawson, let me just walk you through the similarities they have, because in truth, we use a lot of those philosophies today because they're successful, they work. So the concept that came out of nathology and really the other two was this concept we call mutual protection. And a mutually protected occlusion basically means that when the patient clenches, you want them to have very solid posterior occlusal contacts, because the posterior contacts are directed axially along the posterior roots, whereas anterior teeth, if you clench, the anterior teeth, the forces aren't directed axially. So what we say is, in clenching, the posterior teeth protect the anterior teeth, because the anterior teeth, in terms of their forces, would make the tooth have fremitus or be mobile. Whereas if you get solid posterior contacts, that protects that from the anteriors. On the other hand, as soon as the mandible moves, we actually don't want the posterior teeth touching, we want the anterior teeth touching. And so now what we say is the anterior teeth protect the posterior teeth when the mandible's moving. And why do we typically want that? Well, Traditionally, we believe that if we had the anterior guidance, the anterior teeth touching, that the anterior teeth touching would shut muscles off. And because there was some literature that said that. The real question was it the anterior teeth touching and shutting the muscles off, or was it the fact that posterior teeth aren't touching and it's the lack of posterior contacts that shut muscles off? Or in fact, is it not true that that always happens? Today, mechanically, we know that when a person's mandible's moving or when they're clenching, you can put about 8 to 9 times more force on your molars than you can on your anterior teeth. So today, we still use anterior guidance, we still use mutual protection, but we use it because we want the anterior teeth, which are receiving less load, to separate the back teeth and protect them. So again, mutual protection. Posteriors protect anteriors in clenching, anteriors protect posteriors when the mandible's moving. And so essentially, we don't want any contacts on posterior teeth unless the patient's in their intercuspal position. And that fits very well with the traditional approaches to occlusion. Now, the other things that we practice today, for the most part, is when a mandible is going left or right, we typically have the canine be the tooth that's touching. It's canine guidance, the canine separating the back teeth. It's very effective most of the time. But as we're going to see in some lessons coming up, it's not always appropriate. Why? Because the canines are only 2 teeth touching. If you have somebody with significant bruxism or significant attrition, all the force goes to those 2 cuspids. There's times we need to spread it out. Now, again, classic, when the patient goes protrusive, what do we typically want? Want the central's providing guidance. And for the most part, again, that's what we do today. So the big shift hasn't been that nathology or bioaesthetics or Pankey Dawson, that what they did in practice was necessarily wrong or radically different from how we may create an occlusion today. The big difference is the rationale behind why we're creating the occlusion that way. We're not doing it because we believe that if we do the occlusion this way, it's going to stop people from grinding their teeth. It's going to stop people from having muscle pain. We think about it differently today. And of course, as I already mentioned, those 3 philosophies also did want to build the occlusion with the condyle seated. Now, there's times that we do that today, but most of the dentistry done in the world's not done that way, and the patients do fine. So again, in future courses and lessons, we'll talk about when is it appropriate to use a seated condylar position, when do we not have to worry about it. So bottom line, if we go back and you look historically at these philosophies I've mentioned, pretty much this is what we've learned. They're successful most of the time, but they're not always successful. And this is maybe a really important point, they're not always necessary. Every patient doesn't need anterior guidance. Every patient doesn't need canine guidance. Every patient doesn't need to be built with their condyles in a seated position. If we need to change the patient's occlusion, most patients, those philosophies will be an appropriate way to approach that patient. But it's not going to be necessary for everybody. And then the other thing I think it's important to realize is the approach to those philosophies of occlusion is not really what you see in nature. If you look at studies that look at the occlusion of natural dentitions, and there's a lot of different studies that have looked at this, the number of natural dentitions where the intercuspal position is built where the condyle is seated so there's no shift is well under, depending on the study, 1 to 19% fine CR equal to MIP. That means 80 to 99% had some sort of shift in the natural occlusion. If we look at how often does canine guidance occur in a natural dentition, you have to ask the question, how old is the patient in the study? If you study a lot of 20-year-olds, you're going to find a lot of canine guidance. By the time you look at studies where patients are 50, how often does canine guidance show up? 2.3% bilaterally, 10.7% unilaterally, not very often. Why? Because the canines wear and you develop group function. How often do you actually find occlusions that have no posterior interferences in the natural dentition? Depending on the study, 40 to 60% of patients have some sort of posterior interference. And so it's not that what we learned was necessarily wrong, but it definitely is that not everything we learned has to be applied to every patient, okay? So when do these approaches actually not work? When are they not successful? Patients that have unstable temporomandibular joints, when you start trying to seat condyles in patients that have bad joints, that's not typically a recipe for success, especially if it's an unstable joint where the joint's actually degenerating and changing. Or in some patients, you can have a stable joint, but because of disc displacement, there can be discomfort in the joint. We can seat condyles when we have stable joints that in fact we know are comfortable, and we have evidence of stability. Typically today, that evidence would be CBCT or MRI if you know that you have a joint that in the past had a problem. When else do these philosophies have some risks? Airway. All of these philosophies seat the condyle and retrude the mandible. We live in a world today where the rather common approach to manage apnea and airway issues is typically some kind of a sleep appliance that brings the mandible forward or allows it to come forward. So we have some evidence that when you place the mandible in a more retruded position, it closes down the airway. And so again, that's not the kind of approach you want to use in people who have documented airway breathing problems. And then when we think about patients that have really significant muscle activity levels, really high muscle activity levels, lots of grinding, things like canine guidance can be really dangerous because patients will either break the cuspids or they'll make the cuspids mobile. And so oftentimes we need to share the load a bit. So bottom line, confusion surrounding occlusion exists because there's been so many approaches that work. I mean, that's what makes it confusing. And in reality, in my personal opinion, the success of occlusion is really dependent on the patient's muscles. So if you have a patient that just doesn't have very active muscles, almost any occlusion works fine. If you have a patient that has very active muscles, you have to figure out how you're going to distribute the load from those muscles so that in fact they're shared with the teeth and the jaw joints so everything survives. And just to show you a simple example, in our facially generated treatment planning workshop, the students all bring cases into treatment plan. And one of our students brought this particular case in, and it was like, well, what should I do with it? And so you start looking at the case, and you go, okay, it looks like an end-to-end occlusion. There's some little bit of wear on the centrals. There's no wear on canines, premolars, molars. The teeth are, for the most part, beautiful. And then you realize, in fact, the patient has no posterior contact at all. There's no posterior occlusion. Why in the world can this patient survive only hitting on their centrals? Because their muscles are quiet. And so when you have patients who have really quiet muscles, you can get away with all kinds of stuff occlusally that you could never get away with in a patient who actually was an active clencher grinder. And so we really have to think about, as we again look at occlusion, it's a case-by-case basis. What do you do for the patient who's sitting in your chair? Do they really need treatment? Now, this patient, I think it would be advantageous to consider orthodontics because this patient apparently was in their late 30s. I would like to see the patient get a better posterior occlusion to take advantage of mutual protection. Otherwise, they are going to keep wearing their centrals. But I use it as an example to show you this is what quiet muscles look like, and then this is what active muscles look like. Look at what this patient, he's in his 40s. Look what he's done to his teeth, his anterior teeth. So if you can imagine if this patient was only touching his central incisors and had no other teeth touching, what he would have done to the centrals compared to that past patient. So bottom line is the purpose of this lesson was to give you some historical overview about where occlusion came from in terms of the major philosophies, gnathology, bioaesthetics, Pankey, Dawson, neuromuscular, share with you some of their similarities, but really to have you start thinking about the approach that they used has been incredibly successful, and it's still appropriate today for most patients, actually, if you're going to change somebody's occlusion. but the rationale for why you would do it is probably different today than what it's been over that period of time since at least when I was in school in the mid-70s. So I hope this helps you think about what you've heard in the past about different approaches to occlusion, and it gives you some way of understanding why there's so much confusion, because most of them work. I look forward to seeing you in the next lesson.